Welcome to today's UMTRC webinar series. We're going to be hearing from Erin Kochan today from Jersey Community Hospital in Illinois. And our three learning objectives for today are discussing why telehealth is important in the rural setting, sharing steps for implementation, and discussing lessons learned. I do also want to plug another event that is coming up next week. Jersey Community Hospital is going to be receiving an award from the Partnership for Connected Illinois and the Illinois Telehealth Initiative as an underserved rural and urban population telehealth program. And without further ado, I'm going to go ahead and hand things off to Erin.
Thanks, Becky. As Becky said, I'm Erin Kochan, the Director of Population Health at Jersey Community Hospital. I will start sharing my screen so that you guys can see my presentation. Can you guys see it? Okay, perfect. I will tell you a little bit about myself. I started at Jersey Community Hospital in December of 2018 after they received the first of several USDA distance learning and technology grants. It helped provide funding to get 2 of our telemedicine carts. And I'll go into more of that in the presentation, but that's part of why I was hired. As the Director of Population Health, I manage all of our grants and any programs associated with our grants. So we have a medication assisted treatment program through a grant, and we have integrated behavioral health and a chronic care management program all through grants. So I manage all of those. It's kind of about me. So we'll go ahead and start the presentation. As Becky said, the 3 things that I hope you guys take away today is why telehealth is important in a rural setting, the steps for implementing telehealth, and some of the lessons that we've learned. We needed telehealth specifically in our hospital because we are a rural hospital. We rely on our primary care physicians to provide hospitalist coverage overnight. And that was getting to the point where our providers were being called multiple times during the night. So they were being, their sleep was disrupted, and then it kind of started taking a toll on them altogether. So we decided to do a telehospitalist program for nights, weekends, and holidays. This was really important because it has helped increase our admissions during the night, and it's also helped provide a better quality of life for our providers. Our patients are getting additional care at night that previously they wouldn't be able to see the physician until the next morning. This way they are able to see a physician anytime during the night. So that's helped significantly. So what we did to implement our telehospitalist system. Like I said, we received a USDA DLT grant for the equipment, and that we wrote our grant for 2 telemedicine carts. Originally, we were going to do 1 in the ER and then 1 for our medical surgical unit and our ICU. Our ICU is a 4-bed ICU, so it did not get used very often in the ICU, but it was being used more on our medical floor, so we transitioned it just to stay on our medical floor. We started the program in May of 2019. We started the implementation back in January of 2019. And the implementation process was very, very important in ensuring that the program is successful. It's everything from making sure all of the providers are credentialed, getting them educated on the EMR that we use, getting them educated on just our hospital in general, and then also going through the workflow. The company that we contracted with, they had a standard workflow that they sent us, and then we were able to modify it. So we have one workflow for day shift and one workflow for night shift. We don't really use them that often during the day, except on the weekends. On the weekends, they do provide backup for our nurse practitioners that are in-house. And then they do all of the admits in the evenings. And so we had to make sure that we had a lot of staff training and buy-in. And so in this picture, that is one of our telemedicine carts. And the gentleman in the picture, he's with Teledoc, which used to be In Touch. He came out and did 3 training sessions for our employees. We made them mandatory for all clinical staff. So everybody from ER, surgery, ambulatory, and then inpatient. They all had to come to it. All the nursing supervisors had to come to it. And our IT department had to come to them. And a lot of people are like, why would you have your IT department come? The cart itself, if anything goes wrong with it, that goes to, we call the cart company, we call Teledoc, but we want to make sure that our IT is aware of how to use the cart and what they could possibly do to help if the cart stopped working for whatever reason. And then we also did multiple trainings with Eagle Telemedicine, who is the contracted provider for our telehospitalist system. They did multiple trainings with the staff. And again, we had it, we made it mandatory for all clinical staff to come. And they basically walked through what it would look like when we consulted them for a consult. We did everything from texting them to notify, the text notifies them that we need them to do a consult. And then they would beam in, they would talk to us just like they were doing the consult. We have Bluetooth stethoscopes that they asked us to use so that we could kind of hear what it would sound like on our end when they use them. And then Eagle Telemedicine also helps with all of our codes for nights and weekends. Right now, our ER physicians respond at night, and then we consult in Eagle Telemedicine and they run the code. The ER physician will make sure that if the patient needs intubated or anything hands-on, the ER physician will do that, but the Eagle Telemedicine will actually run the code. If they need to have a conversation with families, they will do that. So that, again, was something that was very helpful for our rural hospital. To get staff buy-in, we did a contest to name our carts. So we had 2 employees that submitted names, and we had, I'll take that back, we had multiple employees submit names, but we did a random drawing, and 2 of our employees won a gift certificate to our gift shop here on our campus. And those are the people on the left and right of the screen. The photo in the middle of the screen is our carts. And then that is our former CEO, his wife, and son. The reason that they are in the photo is the carts are named after their other son who passed away from pediatric cancer. So it's kind of very personable to everyone at our hospital because he was working while he was dealing with his son having cancer. So we wanted to make sure that they were involved in the picture so that we could explain the story behind the names. And the names of our carts are Johnny and Jackie. And so anytime we put a request in for a consultation, we have to tell them which cart to log into. Johnny is our inpatient cart and Jackie is our ER cart. And then recently we received a second USDA DLT grant that allowed us to hardwire our 4 ICU rooms for telemedicine. As our census continued to grow, we started thinking, what happens when we have a patient in our ICU in isolation that needs a consultation at the same time as a patient out on the medical floor for specialty services or any other telemedicine services that we're getting soon. So we ended up hardwiring the 4 ICU rooms, which basically means there's a TV on the wall, just like normal. And then the camera is mounted to the wall. We are actually today kicking off a call for our telecritical care program. So the thought behind our critical care program is that we will have intensivists available 24/7 to provide telehealth services to our critical ICU patients. This became more of a need as the pandemic has progressed. We were very lucky in the beginning that we did not experience a lot of positive cases. As the pandemic has continued, our positive numbers have gone up, and we are seeing more patients in the hospital that would benefit from a critical care physician. Because we're rural, the closest tertiary hospital is probably at least 45 minutes away. And these patients that are on a ventilator, they may need something before they're transferred to before they can actually get into one of those hospitals. So we're going to offer the critical care services for our ICU patients in hopes of keeping them stable until we can get them transferred, or if it is something that we can manage here, the critical care physicians will follow through with them. This is a picture of our TV and camera for our outpatient clinics. So we had one of our DLT grants provided the funds for 3 outpatient telemedicine devices. And this is the same setup that is in the ICU. And so we have them in our clinical services building, which houses primary care, pain management, medication assisted treatment, and counseling services. We have one at our Root House clinic that people can come there for consultations instead of having to come all the way to the hospital, because the Root House clinic is about 40-ish minutes away. And then we also have equipment at another clinic called the McDowell Clinic. And in that clinic, the purpose is to use the equipment for consultations from outside physicians. We have an infectious disease provider that does teleconsultations for us. So that's one of the uses that we use this equipment for. We are currently in the process of implementing our primary care telehealth program. Again, when the pandemic started, we decided, hey, what can we do for telehealth for the clinics? And we used WebEx. I don't know if you guys are familiar with WebEx, but it is not the most user-friendly program. So a lot of our patients didn't want to use it. As the pandemic has progressed, we decided we've got to find something different to use. So now we are using, we're in the process of implementing DoxyMe. And again, the providers will transfer from WebEx to DoxyMe, and then they can provide the visits via telehealth. We also made it a priority during the pandemic to ensure that the nursing homes in our community had access to our providers via telehealth. Our providers are the medical directors for the local nursing homes. So we wanted to make sure that they could talk back and forth. And that was a really good service for the nursing homes. They appreciated it. It helped keep the patients in the nursing homes, not as much exposure. The families were appreciative of it. So they were pretty excited about that program. And now that we're going to DoxyMe, we are going to make sure that they can still provide telehealth services for patients in the nursing home. This just kind of shows our volumes. So from January of 2020 through the end of September of 2020, we have done a significant amount of consultations. Our telehospitalist program had 458 consultations in those 9 months, compared to May of 2019 when we started until the end of 2019, they had 440. That number continues to increase. We also had our pain management provider doing telemedicine consultations, and she pretty much started those after the pandemic started. So she did about 66 during that time period. Our primary care providers did 145 consultations via telehealth. Our psychiatrist did 131. And then our licensed clinical social worker did 82. Her visits could have been higher, but the clinic that she is located in is not a primary care clinic, so the same types of patients aren't coming through as a primary care clinic. Like, we wouldn't, if somebody was having COVID symptoms, they wouldn't come to the clinic that she is at. So she was able to continue to see more patients in person. And then in June, we started working with an infectious disease provider for telehealth services. He sees them both inpatient and outpatient. And he had done 13 through the end of September. And I know he's done at least 5 more since then. Again, a lot of these, without telehealth during COVID, we wouldn't have been able to have this much success with continuing to keep visits. We are currently in the process of working with a local hospital who has pulmonology services to contract with them to provide pulmonology consults via telemedicine. So that's kind of our next phase, along with the critical care providers. Our goal is to continue to grow our services and specialties. For the inpatient services, again, we just want to make sure that if there's a specialty out there that would benefit our inpatient population, that we're able to provide it. Pulmonology, like I said, is one that's really important, so we're working on that. For outpatient services, we are looking at every type of referral that we're sending elsewhere. So whether it's pulmonology, infectious disease, dermatology, endocrinology, we're looking at all of those to figure out what priority we need to put all of these with. We do work with SIU School of Medicine in Springfield to do some telehealth visits, but we don't really have a lot of patients that are seen that way. So we're, like I said, trying to get some more inpatient and outpatient services. Implementation tips. Research everything multiple times. Before I came here, I had experience with InTouch and I had experience with Eagle Telemedicine, so I felt comfortable with them, but we still explored other options to make sure that we selected the right vendors for both the services and the technology. You have to have buy-in from your administration, you have to have buy-in from your providers, and you have to have buy-in from your staff. When we told the staff that we were going to have a telehospitalist program, a lot of them came up and said, well, what's going to happen to my job? And we're like, nothing. You're still going to have a job. This doesn't change what you do on a daily basis. This is bringing a physician in when we need them to see a patient in the evening, at night. So once we kind of explained all of that to him and explained that this isn't adding anything to your workflow, it's just helping the patient get better care, they were more supportive of it. Our providers for inpatient services, they were 100% on board because they didn't have to take call and come in on the weekends to see all the patients inpatient, and they weren't getting the calls in the middle of the night. So they were pretty excited about that. As we're transitioning to the outpatient primary care and specialty services, our physicians, again, some of them are more interested in the telemedicine and some of them don't want to use it just because they feel like their patients will still come in and see them. So it's we're not telling all of our providers that they have to do telemedicine visits, but we're encouraging it for the patients that would be appropriate. One of the other big things that you need to research are your expenses. You have to look at what platform you're going to use, and that's basically your technology. We were blessed by the USDA grants to help us cover the cost of the equipment. There is ongoing maintenance that has to be covered. So that's something that you need to look at. You want to make sure that whatever you're using, whether it's inpatient or outpatient, making sure that it is user friendly, both for the patient and the provider. Like I said, the WebEx was an easy fix, a quick fix, and we learned very quickly that it was not user friendly for patients. So we needed to figure out how to get rid of that. If we wouldn't have been trying to do something so quickly because of the pandemic, we would have researched and probably never rolled out WebEx to our providers. Also, make sure you look at the benefits to leasing equipment versus purchasing equipment. A place that I was previously at, they leased the equipment and then they ended up just purchasing it towards the end so that they had the equipment. Your monthly and annual fees, that goes back to the service fees. And that's basically like with the teledoc equipment, we have somebody monitoring our carts 24/7. So if they ever go offline, they call us and let us know they're offline before we even know that they're offline. Usually if they're offline, it's because they forgot to plug the cart back in and the battery has died. That's usually what it is. And then also having the monthly fee enables us anytime we're having a problem to call teledoc. A few weeks ago, we had a problem with one of our carts. It kept shaking, like the cart wasn't physically shaking, but what the physician was seeing was shaking. And when the patients were watching the cart, it was showing the physician shaking. So we called and they replaced, I think it was the Surface Pro that was on it. They replaced that within 2 days. If we did not have those monthly fees, it would have cost a significant amount of money to have somebody come out, look at the cart, and then order the equipment, and then come back out and install it. We would have been paying an hourly fee for each of those, and it would have added up pretty quickly. And you've heard me mention the USDA grants multiple times. I highly recommend that you look into those if you are trying to establish a telemedicine program. Equipment is not cheap. If you don't put it in your budget, it's going to be really hard to write it in and find the funds in the middle of a budget year. So we have been very blessed with these USDA DLT grants, and I highly recommend that you guys look into those if you're interested in doing a telehealth program. The billing part of it is also a little bit difficult. You have to make sure if you're having, like with us having a telehospitalist program that sees the patients at night, and then our own providers seeing them during the day, we can only bill for one visit per day because they're the same specialty. So if our hospitalist sees the patient at 10 o'clock in the morning, and then our telehospitalist sees the patient at 9 o'clock at night, we can only bill for one of those. A lot of times we see that issue at when somebody's admitted after midnight. The telehospitalist will see them at 1 a.m. and then we see them the next day. Again, we can only bill for one of those services. If it's multiple specialties, then you can bill for both. And then the documentation, you have to make sure that the provider puts in their notes that the visit was done via two-way audio visual telemedicine, what time the consultation started, what time it ended, and that you had patient consent to do it. What we did was we made a template for our providers in their documentation so that they just go in and type the time it started, type the time that it ended, and they click a box saying that it was two-way audio visual and that patient consent was received. That's been a lot easier than trying to remind them each time to, hey, don't forget, you need to put this in your notes. Some of our physicians even put the billing code in their notes. Some of them don't. That's totally up to them. Credentialing is also something that takes a while. It is probably the longest step in the entire program to get them credentialed, not only with your hospital, but also with all of your payers. And that usually takes 90 to 120 days. If the company that is providing the telehealth service is Joint Commission accredited and the hospital that needs the service is Joint Commission accredited, you can do credentialing by proxy, and that will shorten the time frame to get them credentialed at the hospital level. But again, you still need to get them credentialed on the billing side if you're going to bill for the services. And that's one thing that you would negotiate with the company providing the service. For infectious disease, our critical care and intensivist program and our hospitalist program, we have all of the billing rights. So that basically means that we bill the professional fee for each of those providers. Some places only say that you can bill the originating site fee, which is something that you do on the outpatient side. If you are not the ones billing, then don't go through the entire payer credentialing process. That should be the company that is providing the service, getting these providers added to the payers. You'll need to provide a list of who you're contracted with for financial reasons, but that company should be the one contracting with the different payers, not you guys if you're not billing for it. When you do your training, make sure that you do training on not only the equipment, but the process. Like I said, we had training, 2 different trainings, one with just equipment, learning how to use it, learning where everything was. And then we had one with the telehospitalist to actually walk through the entire process. And even now that we've been in it for 1.5 years, we noticed that sometimes it's easier and quicker to see a new patient in the ER versus waiting until they get to the floor. So we changed our process a couple months into it. It's not a big deal. Again, it's just figuring out what works best for your hospital. We also did a mock go live. So about a week before we actually went live, we did mock trial runs. So that's where we said that there was a patient in the ER that needed to be admitted. The ER would contact the telehospitalist. The telehospitalist would beam in to see the patient, determine if the patient needed to be admitted, admits the patient, puts the orders in the computer. That was our mock go live, just to make sure that every aspect of patient care was addressed, and that we didn't need to change anything in the process. And then we went live, and like I said, we've changed some things now from when we first started, but the go live was very effortless because we had done so many trainings and mock sessions. Whenever we said, okay, it's live, when you need a consultation, this is how you do it, they had no problems. And that's really important, just to make sure that the process continues to go smoothly. We also review our program every month. For about the first year, we had a call once a month with Eagle Telemedicine, and it was both clinical people and non-clinical people to make sure that everything was working as we expected and everything was working as Eagle Telemedicine expected. If we identified something that we needed to change, During that call, we would figure out who's going to be responsible for taking that outside of the call and getting it changed, and then bringing it back to the group to let them know, hey, we've changed this process. Here it is. Let me know how this works in the next month. We now do the calls every 2 months, just because we feel like the process has been tweaked a lot and we haven't been running into any issues. Now, with us adding the intensivist program, we'll go back to monthly calls for probably a year with the intensivist program to make sure that everything's still working smoothly with it. Lessons learned: research everything. You cannot research enough. Don't just go with your first person that gave you a quote for the service or the equipment. Get multiple quotes and ask if you can talk to people that already use them, whether that's the vendor for the equipment or the vendor that's actually providing the service. Ask to talk to people that have worked with them. Eagle still contacts me a couple times a month saying, hey, this hospital's interested in working with us. Do you mind if we give them your number so they can reach out and you give them a review? Absolutely. So make sure you research everything. Buy-in, like I said, you need to make sure that you have the providers, staff, and administration on board, as well as the patients. When you're trying to get everybody on board, you have to show why it's important. So what we did was we knew how many patients we were not admitting because overnight, because it was easier for the physician to say, just transfer the patient versus, okay, admit them. I'll get in the computer. I'll put my orders in. I'll see them in the morning. And so they just said, hey, transfer, transfer, transfer. So when we kind of explained to them how they would not be getting all those phone calls, they were pretty excited. They bought in very quickly. Again, with the staff, like I mentioned, once they knew that their jobs were not being eliminated, they were fine with it. And the patients have really embraced it. They enjoy being able to have a physician see them at night if something's going on. The patients who are admitted in the evenings and nights actually get a consultation with a physician then versus waiting until the next day when somebody comes and does their rounds. So any questions they have, they can ask the provider at that time. Billing, like I said, make sure you look at everything on the billing aspect. Make sure you have your codes, make sure you have documentation, and make sure you know if you're allowed to bill the professional fee and that your providers are credentialed with all of the insurances. I think I skipped credentialing, but again, same thing, just make sure that you know if the company you're contracted with is Joint Commission accredited, then you can do credentialing by proxy and the process goes a whole lot faster. And my final lesson is don't rush the implementation. If somebody came to me today and said, hey, we need this ICU project to go live by a week from Friday, I'm going to look at them and say, it's not going to happen. We have to get the providers implemented. We have to get the providers training on our EMR system. We have to get the staff trained on what to do when we have a consult. How do you contact the provider for a consult? Don't rush it. If you rush it, your success is not going to be there and you're going to lose the buy-in. I think that's it. So if anybody has any questions, I can take those now. And my information is on the screen. If anybody wants to reach out after this with questions, you can absolutely do that too. And I think Becky will have my information so you can contact her as well.
Absolutely. So now is the time to ask your questions. We want to have you put those in the Q&A function so we can record those for posterity, or if there's anything we need to follow up on, we know who asked it and we can go back, track through your registration. I wanted to ask a couple questions about the DLT telemedicine program. You mentioned that. It's been a long time since I've looked at it, but I'm curious if you are familiar with the objective scoring in the most recent applications. Has it changed from the way it used to be?
As far as I know, it has not changed. We now have 3 DLT grants, and we have one application out that we did during the COVID. They
Mhm.
call it the COVID window. From the 3 that I've written, I haven't really seen anything change other than they've added opportunity
Mhm.
as an opportunity hotspot, I think is what they
Mhm.
call it. But you go to some website and you put the address in, and it tells you if you're in one of those
Mhm.
opportunity sites or not.
Mhm.
Um, on the COVID one, they added opioids
Mhm.
along with the STEM. It used to be that you could apply either under the opioids, and there was so much funding for opioid related and then so much funding for non-opioid related. They combined those into one. Um, those are pretty much the only changes that I've
Mhm.
seen.
They haven't changed the match funding?
No, it's still a minimum of 15%.
Okay. Sometimes for smaller organizations, that can be a daunting part of that.
It is. It is. Like I said, we've had so many that we've figured out when we're doing the application, we always look at it and go, okay, this is, if we get this, this is how much we're going to owe. Where
Right.
can we find that funding?
Mhm.
And we've kind of gone that route.
Mhm. Yeah, I know the other thing that sticks with me from when we did the application many years ago was um, having to research the national school lunch percentages because that's big part of the scoring for the rurality of the project.
Yeah. And from what I've noticed, because we do the DLT grants and we also do the HRSA grants,
Mhm.
the DLT grants aren't as critical when it
Mhm.
comes to your rurality.
Mhm.
You still have to have a score, but it's like we have a clinic that is in a very rural location that, like, when the Mississippi River floods, they can't get in or out.
Mhm.
For HRSA, it's not rural. Yes. For the USDA DLT grants,
Mhm.
it's rural. So it's one of those, it goes
Yeah.
back and forth. But again, they give you a link to go in and figure out your rurality. So that makes it pretty easy.
Mhm. And then I wanted to ask, so you've gotten quite a bit of let's utilization, let's use that word, out of the telehospitalist program, and you're having a lot of visits. Have you gotten to the point where it's time to use a local person, or is the person that's doing the telehospitalist service for you contracted through a vendor?
It's contracted through Eagle Telemedicine.
Hmm.
Um, Ideally, we would like to have our own hospitalist 24/7. Right now, we have 3 allied health professionals that provide the service during the day. And our chief medical officer backs them up. If he's not available, then Eagle, we notify them and they'll back them up. Um, Being a rural hospital, trying to afford somebody on site 24/7 can be a challenge.
Hmm.
I'm not saying that contracting out is cheap by any aspect at all, but it was kind of our only option at the time.
Hmm. Yep,
And we did
absolutely.
contact some of our local regional hospitals to see if they could provide the service. But there were issues with, we didn't have the same EMR as them, and the only way they could do it is if we had that EMR, and the cost to get that EMR was
Mhm.
way more than it was to contract with Eagle.
Yep. Yeah, I've heard many, and then speaking of platforms, you made me think of that. I've heard many programs that are using doxy.me. So I think that's a good choice. Everybody that I've talked to that has used it has said it's very user friendly and the patients like it as well as the providers.
Yeah, and that's one thing that we looked at after we launched the WebEx and learned it was not the best solution. We looked at several different platforms. USDA told us that Zoom is not compliant. They have known about several breaches. So we checked that off the list. And then we're a part of an ACO, ICANN. So we talked to a lot of our ICANN fellow members to see what platforms they were using, recommendations, that kind of thing. And a lot of them were using Doxy.me. And then I used it as a patient for my kids. And I even said it was the easiest thing there is. Good. So we did our due diligence and we looked at several different platforms and we talked to people who were using them to get their input as well.
Very good. I'm not seeing any questions come in, so I'm going to go ahead and put the link to our survey, and it's just a couple question survey. Let me put that here in the chat. If I can get back to that on my computer here. Here we go. And I did have a couple other questions that occurred to me throughout. I specifically wanted to ask you, Erin, about the whole credentialing thing. So I know the credentialing at the hospital level and the proxy is awesome if you can use it. And then the other thing is you mentioned, but didn't really dig into, actually, let me type this. Here's the survey. Can't type and talk at the same time.
That's okay.
All right. You mentioned insurance credentialing. So what's that like at the Medicaid level in Illinois? How long does that generally take?
For all of ours, we're between 90 and 120 days.
Okay.
It's one thing if, like for our telehospitalists, they were not already working in another Illinois hospital. So it was a brand new hospital, everything. Some of our providers, like our primary care providers, when they transfer from one organization to ours, because they're already licensed in Illinois and already approved for Illinois Medicaid, it goes a lot quicker. It's like a change of address type thing, but we're not always that lucky.
Right. And then what about enrolling with other, well, okay, so we talked about Medicaid. What about Medicare?
It's the same thing. If they're not already practicing in Illinois, it takes longer. They are practicing in Illinois.
Okay. I'm trying to think. I think that's all the questions that I have. I haven't seen anything come in yet from our audience. So at this point, I want to thank you very much for your time today and your experience. It's invaluable to be able to share success stories across our region, and we appreciate it very much.
No problem. And like I said, if anybody does end up with questions, feel free to reach out.
Okay, well, thank you very much, and everyone have a great rest of your day.
Bye.
Bye, thank you.